Welcome, everybody. We're just going to wait a couple more minutes before we get started officially. All right, so I know people will keep trickling in as they get settled home for the evening, but just want to get started and say hello and welcome to our webinar, which is exploring how to center empathy in the latest research to improve the lives of birthing people experiencing substance use disorders. We're so glad you've taken the time to come to join us live or via this recording afterwards. This event is brought to you by the University of Michigan Addiction Center, the Partnering for the Future Clinic at the University of Michigan Health, von Voigtlander Women's Hospital, and the Michigan Medicine Department of Psychiatry. I'm Joanna Quigley. I'm a child and adolescent psychiatrist. I take care of adolescents as part of our addiction treatment services here at Michigan Medicine. But I also trained as a pediatrician. And during my years of training, which was at the University of Kentucky, we took care of so many women who were struggling with opioid use disorders. This was back in the mid 2000s when the opioid epidemic was really hitting Appalachia, and I would be taking care of babies who had had some degree of exposure in our neonatal ICU or in our birthing center, and then also would take care of moms who would be admitted for supportive care as part of their treatment for opioid use on our psychiatric services. So it was a really rich opportunity to start understanding what was happening in this population and what their needs were. So I'm thrilled tonight to be able to learn more with all of you about how substance use disorder is impacting this population and hear more about how we can be mindful about approaching this care. So substance use disorder is a chronic medical condition that affects 1 in 6 Americans. Even though substance use is just as common as other health conditions like asthma or heart disease, we know that stigma remains very high. This is especially true when people who use substances become pregnant. Pregnant people with a substance use disorder often face the highest levels of stigma and judgment, and substance use during pregnancy also comes with health risks for the parent and child that are important to address. Tonight, we are going to hear from 3 of our Michigan medicine experts who provide care to birthing people with substance use disorders. They will break down why it's crucial to provide compassionate, supportive, respectful care, as well as what those of us in the community can do to better support loved ones experiencing substance use disorders and addiction during pregnancy. Dr. Joshua George, MD, MPH, is a maternal fetal medicine fellow at the University of Michigan. He completed his bachelor's degree in cell and molecular biology from the University of Michigan, followed by an MD and master's in public health at the University of Miami Miller School of Medicine. He then completed his obstetrics and gynecology residency at Detroit Medical Center, Wayne State University, and his clinical interests are in the care of high-risk pregnancy with a special focus on individuals with substance use disorder and psychiatric comorbidities in pregnancy. His current research work is centered around optimizing prenatal care for these patients, as well as translational work focusing on cortisol regulation in pregnancy. My colleague, Dr. Maria Music, MD, MSc, is a professor of psychiatry and obstetrics and gynecology at the University of Michigan. She holds a medical degree from the University of Vienna, Austria, and completed residency in psychiatry, both at University Hospital in Vienna and here at Michigan. She also holds a master's degree from the University of Michigan School of Public Health. She is the medical director of the Perinatal and Reproductive Psychiatry at Michigan Medicine and of MC3 Perinatal Program, the statewide perinatal psychiatry access program for primary care. At Michigan Medicine, Dr. Music co-directs Zero to Thrive, a program to support families who are challenged by adversity to help them thrive across pregnancy to postpartum. She is also the perinatal psychiatrist for the Partnering for Future Clinic, which will be discussed here. She co-developed the Strong Roots program, a menu of resiliency-oriented interventions. Her research work focuses on the impact of adversity and mental illness in the context of childbearing, on caregiving and the developing parent-child relationship, and how to support families in overcoming psychological and environmental adversity. She is very well published, and her work is funded by federal and foundation awards. Chelsea Cayley is a licensed clinical social worker, LMSW, and certified advanced alcohol and drug counselor. She has worked at Michigan Medicine since 2022. She primarily works as a therapist in the perinatal and reproductive psychiatry clinic, and the remainder of her time is spent as a perinatal behavioral health consultant with the MC3 Perinatal Patient Care Program, working with birthing people with substance use disorder or chronic pain. She co-facilitates Strong Roots parenting groups for individuals in this population as well. Prior to joining Michigan Medicine, she worked in a tribal behavioral health program as a therapist, in obstetrics gynecology clinics as a BHC or behavioral health consultant, and in community mental health as an infant mental health home-based therapist. Her clinical interests are perinatal mood and anxiety disorders, co-occurring disorders, and complex trauma. Each of our presenters will give a brief presentation. If you're watching this live, you can submit questions at any time using that Q&A feature at the bottom of your screen, and we will pick some to discuss towards the end. We know that there may be many questions, so we will likely combine some that are on the same topic, and please know that our experts can't give specific advice for an individual situation you might be facing. We understand, too, that the topics we will discuss this evening could be triggering for some viewers. We encourage you to protect yourself and step away if any portion of this presentation feels intense. If you cannot stay for the whole chat or want to share the recording with a friend, you'll be able to watch this webinar again later via the Michigan Medicine YouTube channel. We are also sending the recording to all registrants along with a list of resources mentioned in today's webinar. So without further ado, I want to go ahead and have Dr. George start the presentation.
Thanks, Dr. Quigley. Thanks to all of you for logging in tonight. We're so glad to be able to share a little bit about this very important topic during pregnancy. My name is Joshua George. Like Dr. Quigley mentioned, I'm a fellow in maternal fetal medicine, and so excited to be presenting and sharing with you all today. Just wanted to confirm that everyone can see the slides. Maybe Stephanie, can you confirm that?
Yeah, we can, Josh.
Okay, great. Awesome. Well, let's get started then. Tonight, we're going to be focusing on substance use disorder and navigating pregnancy with substance use with care and support. Myself and my co-authors, none of us have any financial or other disclosures on this topic. Tonight, we'll be going through why this diagnosis of substance use disorder is important and how it affects pregnancy. We'll be talking a little bit about screening and treating this condition during pregnancy and what medications and what other interventions can be done in these contexts. We'll be talking about psychiatric comorbidities and how to provide effective, patient-centered, and trauma-informed care. And we'll spend time talking about how a multidisciplinary team can provide wraparound support, which is so vital to ensuring success in pregnancy and postpartum. Let's dive into why this condition is so important for pregnancy. We'll be talking about a variety of substances with a particular focus on opioid use disorder, as it is the most prevalent substance use disorder that we encounter. But just to start off with some definitions, opioids are known as painkillers or narcotics. They're substances that historically have been used for pain relief as well as recreation. The original substances are natural and come from a derivative of the poppy plant. But nowadays, the class of medications and substances are both synthetic and semi-synthetic. These substances attach to opioid receptors in our body, and they create a sensation that blocks pain, but can also create a sense of euphoria. These substances are highly addictive. Examples of opioids that you may have heard of include heroin, fentanyl, morphine, codeine, and then prescription medications such as oxycodone or hydrocodone. Really, for both opioid use disorder and substance use disorder, it really comes down to dopamine. And dopamine is a hormone that is present in all of our bodies and is really important for our normal functioning. When there are various examples you can see here, but when there is increases in dopamine, that creates a sense of pleasure or euphoria. These opioids and other substances raise dopamine levels to significantly higher levels, and that really kind of underlies their addictive sensation when we are constantly seeking that higher level of dopamine. We know that in terms of this crisis of substance use disorders, primarily driven by opioids, and it is ever evolving. Initially, the diagnosis and the public health problem was really noted in the 1990s when there was noted to be a rise in opioid overdose deaths secondary to prescription medications. The second wave really began in 2010 when we saw a rise in heroin overdose deaths. Right now, we're in the midst of kind of the most recent wave, which really is comprised of synthetic opioid overdose deaths. And these are medications that are synthetic, such as fentanyl, which has really been a really devastating substance in our population. The We'll talk a lot about pregnancy, but I really want to stress that this condition is not just limited to pregnancy, but really tends to affect people in the postpartum people as well. Data we have shows that the majority of people who unfortunately pass from substance use disorder, those deaths occur after pregnancy or in the postpartum period, up to 75%. So we'll talk a lot tonight about how providing care extends past just labor and delivery and all the way through the postpartum period. Just again to stress, you may hear in the news about the rising levels of maternal morbidity and mortality in the country, and that's due to a variety of conditions. And we often think of things like bleeding or cardiovascular disease or trauma, but in fact, the number one cause of pregnancy associated mortality or passing away is actually substance use disorder. So it's something that is not as often talked about, but is extremely important to our pregnant population. We face two crises, just like I've been mentioning, that are happening kind of at the same time. The first is higher rates of maternal morbidity and mortality. And in the US, unfortunately, despite our resources in healthcare, we lag behind our peer countries in terms of keeping our moms safe and healthy. Um, the other epidemic is the opioid epidemic, like we talked about, and we do see increasing rates of opioid use during pregnancy and increasing rates of its effect on infants, or we'll be talking about neonatal opioid withdrawal syndrome. Just to kind of put into context how these conditions affect pregnancy, the biggest thing that we see is that, like Dr. Quigley was mentioning, there's so much stigma associated with these conditions, and it really keeps people away from routine, regular prenatal care. That, in and of itself, is a huge driver for um, problems during pregnancy or missed opportunities to intervene for other medical conditions. And it really comes down to people not feeling comfortable to access a routine prenatal care. Um, we'll dive into these things a little bit more with specific substances, but there can be specific pregnancy related problems with specific substances. Things like birth defects with alcohol and stimulants, fetal growth restriction, which is a condition in which the fetus does not reach its growth potential, excuse me. And then other conditions such as placental abruption or preterm labor, which may increase the risk of needing or going into labor early and needing to stay in the NICU or the neonatal ICU. We also think about how these substances affect babies after they're born in terms of a withdrawal type syndrome, as well as effects for mom. So, risks for maternal overdose or passing away, high risk activities in terms of how substances are delivered, which may put people at risk for infectious disease and other complications. And then definitely a high rate of co-occurring mental health conditions that often go unaddressed during pregnancy and postpartum. What we do know is that a lot of these adverse outcomes can be mitigated through routine prenatal care and treatment for substance use disorder. And a lot of that we'll talk about comes by decreasing stigma and increasing our ability to access patients and provide them great comprehensive care. We want to be mindful of stimulants, and this is a list that kind of talks about the major ones that we see in pregnancy. It's not comprehensive, but these are the main things that we think about. We've talked a little bit so far about opioids. Stimulants are very common in our local population in the state of Michigan. These are substances like methamphetamine or cocaine. You can see some of the effects that they may have on pregnancy. Alcohol, we talk about a lot with patients, but certainly has increased risks for things along the neurodevelopmental spectrum. Benzodiazepines are medications that have high addictive potential as well. And then we all are probably more and more increasingly more familiar with cannabis or marijuana. And we'll touch on this a little bit more, but there's just a lot that we still don't know about cannabis and its effects on pregnancy. But the early data is not positive and comes with risks for growth restriction, stillbirth, and neurodevelopmental effects later on in childhood. One of the biggest drivers of all pregnancy risk still is tobacco. And we know that there is tobacco use is strongly associated with a lot of these similar problems as well. Cannabis, we know, is becoming more and more common in pregnancy as it has become legal in the last few years in the state of Michigan. There's not a lot of great data because a lot of the um, exposure in pregnancy is still yet to be studied. But what we do know is that there are increased risks for both mom, baby, and some that last into childhood. For mom, there are some small increased risks of going into labor early or developing high blood pressure during pregnancy. Babies may be at risk for, again, not meeting their full growth potential or potentially needing admission to the NICU. And then a lot of the work that is still being developed is exposure risks into childhood in terms of developmental effects and things like executive functioning skills, memory, attention, and impulsivity. Birthing people in the US, they face a lot of challenges, including criminalization, stigma. And what I really want to highlight here is that in Michigan, clinicians are mandated to report suspected child abuse and neglect in terms for symptoms or suspicion of alcohol or controlled substance use in the newborn. And Chelsea will kind of talk about this and talk through this a little bit more in a little bit. Let's talk briefly about best practices and how we really aim to model comprehensive and patient-centered care when it comes to screening and treating for opioid and substance use disorder. This comes up a lot for our patients, and it's really one of the things we wanted to highlight, the difference between screening and testing. Screening is verbally or electronically asking questions to patients about their substance use, whereas testing is biological testing, often through urine. A lot of patients feel hesitant to access healthcare because they have had their trust violated by providers who may have tested their urine without their consent. So we really aim through our clinic to screen verbally, and then when testing is appropriate, to do it with consent and share with patients why we're doing it and what the implications are. We use a couple different tools, but the goal is really to get a comprehensive picture about someone's exposure to substance use and how they came into that, and how we can really best help them address that issue moving forward. The kind of main principles that we try to focus on in treating opioid use disorder and substance use disorder are identifying the substance use, understanding paths to recovery, understanding comorbidities and other things that contribute, and then really providing close wraparound follow-up and support. We talked a little bit about how we screen, but again, it's not just, it's really understanding how people came into the situation or made the decisions that they chose to make, and how we can best work with them on moving forward. We really also try to understand what things have they tried before and what things have they experienced through the healthcare system, and try to address those barriers moving forward with their pregnancy and postpartum care. There's a couple medication options for opioid use disorder, and we really stress these as for individuals who want to move past using opioids. There are a couple medication options that can help with withdrawal and craving symptoms. These are things that you may have heard of, such as methadone, buprenorphine, or naltrexone. Buprenorphine is also commonly known as Suboxone or Subutex. We recommend these for pregnancy as opposed to opioid use, as they really show benefits in terms of accessing prenatal care and preventing overdose and accessing routine prenatal care. We really try to stress with patients that this is not replacing one drug with another. It's really thinking about substance use disorder as a chronic disease and using medications to help to get back to one's baseline and reach that normal level of dopamine. But it's not replacing one drug with another. We know that in pregnancy, things change. So a lot of times we see patients who are on a stable regimen of medication, but then their provider may or may not feel comfortable continuing that prescribing during pregnancy, and they come off or they lose access. But we know that maintaining a lot of these medications during pregnancy is safe and overall beneficial. The other big misconception that we work through with patients is we know that the dose of a medication for opioid use disorder is not related to the risk of withdrawal syndrome for the baby. So we say that the medication should be titrated to the patient's symptoms. I won't go over this in detail, but just this will be provided for everyone to look through what the different types of medications are. We often get questions about patients asking why they shouldn't just try to withdraw in a medically supervised fashion. And the reason is there's really strong evidence that going through a medically supervised withdrawal is associated with a very high return to use rate. it also is not the best way to create engagement with prenatal care and that routine prenatal care, and leads to higher rates of both pregnancy complications as well as infectious disease. Um, Other substances are a little bit more limited in terms of their recovery medication for recovery options. Marijuana, there's no FDA approved medication substitution for marijuana. Same thing with cocaine. No, there's no alternative or substitute medication that can be used safely. So we manage these conditions in integrated clinics and really consider how psychosocial support and rehabilitation programs can be beneficial in maintaining um, cessation of use. Um, I wanted to briefly touch on alcohol use disorder, and we know that sometimes there are conflicting recommendations, but there is really no safe time to drink during pregnancy or safe amount of alcohol to use during pregnancy. The kind of mainstays of treatment for those who are using alcohol during pregnancy are centered around psychosocial interventions. And there's a couple of medication options that can be utilized as well. But engaging with patients, even for brief periods of time, can really make a difference in decreasing the risk of drinking during pregnancy. What we really want to stress is that this is a process and not a once or a singular event or a one-time event. Recovery comes with ups and downs. Recovery is a journey, and we, as a medical community, have learned to understand that better. And our goal really is to walk with patients through this pregnancy period and postpartum period, despite the challenges. Um, the I think my colleagues will kind of talk about this, but we'll talk a lot about mental health and social drivers of these conditions and really understanding how that plays into it. Um, there'll be more information available on labor and delivery, but the for a lot of individuals, there's so many questions about what their experience with delivery will look like. So there are a lot of protocols that we've developed and a lot of great partnerships we've developed with our anesthesia colleagues and nursing colleagues in terms of caring for patients in that acute labor and delivery space. Um, the the kind of main philosophy or program that we focus on here at the University of Michigan, and that happens more and more around the country, is called Eat, Sleep, Console. It is a patient-centered and neonate focused way to really look for signs of opioid withdrawal syndrome, as opposed to a prior model, which really put things in the uh, neonatal ICUs kind of basket. This is really a way for parents to take ownership and to really engage with their healthcare providers and with their baby and provide support if withdrawal is noticed. Um, with that, I'll pass it off to Dr. Music.
Thank you so much, Josh, for kind of guiding us through the beginning. Shall we just leave it with you advancing the slides
Sure.
and
Happy to.
I just thank you so much. I
Of
appreciate
course.
that. Um, Although you just gave me permission, no?
I did not.
No, you did not. Okay, so I would love to kind of talk a little bit about the psychiatric, the psychological sequelae and comorbidities. Um, Next slide, and kind of start off with it saying that the um, time in pregnancy and postpartum is already even without kind of substance use in the picture, a time of heightened vulnerability for women to have mental health issues. If next slide, if you advance, when we look at the prevalence or comorbid, like the how common are certain psychological um, conditions like depression, anxiety, bipolar illness, trauma, post-traumatic stress disorder, you see that the numbers are actually quite high. It's pretty common. One of the most common is depression. Depression, 1 in 5 women experience depression either in pregnancy or postpartum, and depending on the risk of the life circumstances, this can be even more common. Anxiety is very common. Postpartum anxiety is more and more. There's anxiety in pregnancy and fear of childbirth then, and then postpartum anxiety, very, very common. Next slide. However, when we put together kind of that picture of the patients that we see who are also struggling with a co-occurring substance use disorder, we actually realize that there is this interplay of so many factors or co-occurrence of all these presentations at the same time. And one of the major pieces in this equation is the exposure to trauma. So women who have trauma histories starting from maybe childhood and then carried forward into adulthood as domestic violence, interpersonal violence, that then creates a psychosocial risk constellation or is co-occurring with what we call social determinants of health as DOH, which means difficult psychosocial circumstances from poverty, loneliness, social isolation, poor access to support. And in this context, it's very common to then show all of these co-occurring presentations, feeling depressed, feeling anxious, having post-traumatic stress disorder, and then often also often starting as a self-medication or, to ease the pain, the emotional and physical pain with substances, and then it becomes a self-occurring process, self-perpetuating, and that a substance use disorder. So advance with that, the so-called comorbidity, which we in the psychiatric world, that means the co-occurrence of one or more psychiatric conditions. You can see it's very high. The overlap of all these together is between, for the lowest, 30% to 80%. So it's very, very coming as a package. And that's very important for us to understand. Next slide. So I hope that I was driving home that trauma is a major player, and that 80% of the women that struggle with addiction also report some type of physical or sexual assault in their life, and that sets them up to be more likely to develop a condition that we call post-traumatic stress disorder, as an anxiety disorder, as a sequel of traumatization. Next slide. Just kind of as a side note, trauma is very common among women to begin with. In the United States, 1 in 4 women have been sexually abused growing up. We think that 1 in 5 women experiences interpersonal violence as an adult. We know that violence is not uncommon also during pregnancy. So pregnancy is not protecting from interpersonal violence exposure. And then in the context of all these prior violations of safety in interpersonal space, many women also experience then the birth and the interaction with the providers, but also the birth experience per se as traumatic. It's 30% of women. In this context, women are therefore more likely than men to develop a condition based on traumatization. That's called post-traumatic stress disorder. Women actually twice as likely across the lifetime to have it than men. Men usually get it through combat exposure or other physical altercations in their lifetime that are through some interpersonal physical assaults. But women are actually much more likely than men. The strongest predictor is childhood abuse. And even women who might not have had prior trauma exposure might develop PTSD de novo, which so out of health due to traumatic birth. And PTSD is almost like a vulnerability factor. Once you have this condition, you carry it forward. Even if you get better, it kind of stays with you and is a waxing and waning condition. And is a really very important psychiatric comorbidity that needs to be addressed and supported and treated, because otherwise it's kind of like an elephant in the room. It's always with you and shows up in various ways. Next slide. I want to kind of bring this up. I'll get to this in a second. One word about these childhood adversities. You might have heard about the very famous adverse childhood experiences work that's already started, a study that was already starting in the 1980s, where we found that these early childhood adversities, such as being exposed to physical or emotional neglect or abuse, and having parents with mental health problems, having parents who were incarcerated, having parents who themselves have substance use disorders and were maybe neglectful or abusive or were struggling, that all these early childhood adversities are setting people up in their adult life across the lifespan to risk, both physical as well as emotional. I just want to highlight that these childhood adversities are kind of based also or rooted in adverse community environments that we are seeing in some communities more impacted than others. And that is kind of a bigger social problem of communities exposed to poverty, discrimination, lack of opportunity, poor psychosocial context. So it's a co-occurring of kind of these most societal traumatizations and discriminations that are then superimposed and potentially laying the ground for individual level childhood adversity. Next slide. Why is this important to understand? It is important to understand the trauma and all this complexity, because once traumatization hits kind of your mental processing, and the younger you are, just the when you get traumatized, the more impactful it is, because it stays with you as a kind of a template for development and life. It really changes your worldview. We call it's a violation of your assumption about the world and life. And the violation is a relational trust violation. So individuals who have been traumatized, particularly early on in their life, and then repeatedly, they become mistrustful of people meaning well and wanting to help. And that, of course, applies also to health professionals. And also, the second violation is about the self. Am I effective? Am I efficient? Am I worthy? Am I lovable? Am I capable of changing my destiny or kind of living my life? So it's this violation of self-perception. And that these two aspects, these violations, change how this individual then across their lifetime is able to regulate their emotional life, when things become harder, when there is stress, when there is challenge, they are more likely to become emotionally dysregulated, maybe rageful, angry, or withdrawn, or needing to numb themselves. And it leads to psychological isolation. And you can imagine that in this context, it might be more likely that I then wish to self-medicate this emotional pain with some uh, painkillers or substances just to kind of make it through this emotional dysregulation. And in addition, as you can see on the right side, it changes also help-seeking behavior. So more withdrawn, less trusting the health providers. This makes it harder for us as providers to connect and offer help. Or we have to understand that the patient might need an extra nurturing and an extra supportive environment in order to be willing to engage. As Josh said, less prenatal care, less ability to engage with prenatal care. More mental health problems, and then also more problems in parenting. So all this is important because the impact of the trauma is common, changes the worldview, impacts mental health, and is then multi-generational, impacts parenting as well. Next slide. As that means, we in our trauma-informed care need to understand this, and therefore the number one aspect of our care in working with individuals who have been traumatized and have complex psychiatric and substance use disorders is to create safety, to show ourselves as trustworthy, dependable for them, to show ourselves as collaborative, to help empower the patient, to be compassionate and empathic to the patient's life. And then also, this is hard work. So to also keep self-care as the provider to prevent burnout. Next slide. So I want to kind of walk you through a couple of examples. What does this mean in real kind of day-to-day life and work to be trauma-informed in our care delivery? Next slide. One aspect is that our words matter. Our patients are very sensitive to what kind of words do we use to describe their condition or to talk to them. And it has to be empathic, non-stigmatizing, non-shaming, and supportive. So you have here a couple of examples. Terms like, oh, you're clean or sober, that's demeaning. It's substance-free. Or calling someone an addict needing to get clean, or instead of using the word a person is in recovery or seeking recovery. So it's really important to be encouraging and also to think, to be collaborative. As we said, treatment is done with the patient, not to the patient, and kind of be keeping hope and holding the hope and seeing the small wins. It's a relapsing. It's a as Josh said, it's not a one-time event recovery, but it's a process, and kind of holding that in mind. Next slide. This is another kind of suggestion in kind of how to talk about not saying now that you are pregnant you need to stop smoking. So instead of saying that, where we are driving and telling the patient what to do, is kind of to open it up and say, what do you think about this? What are your thoughts about this? Next slide. Trauma-informed care means that we need to realize that trauma is widespread, that we need to recognize the signs and symptoms of trauma in our clients, so PTSD, to screen for it and to address it, and then to respond to it and make sure that we are not re-traumatizing our patient in the care that we deliver. Next slide. So this is just kind of another display of how we are trying to do this with different strategies in our day-to-day work with our patient. That means that our clinic staff needs to be trained in this worldview, and we all need to provide an integrated, collaborative way of holding and nurturing the patient, and really not trying to be enhancing the resilience and not traumatizing the patient through our way of being in the clinic. Next slide. As Josh already said, the number one fear for patients that keeps them away from prenatal care, which then has detrimental effects on the health of the mother and the child, is that they feel judged, stigmatized, and fear, and therefore not present to care. Next slide. Yeah. Harm reduction means we want people to come back. And so another aspect, next slide, is to sometimes we are not thinking about all or nothing. Recovery is not all or nothing work. It is sometimes meeting the patient where the patient is in their journey of contemplation and action towards recovery, and making sure that they are one step towards a safer handling of their illness. So, for example, making a parenting plan. If the patient knows that they might want to use, that they have craving and they might use a substance, to make sure to arrange safe childcare and making sure that the child is with someone else during that binge attack or during the use. And so to know also what to do in an emergency. So that is reducing harm without judging that everything has to be, to completion of recovery. Next slide. An important piece is that, as we said, there are many social determinants of health or resilience or the lack of. And so really care needs to be a team care, because we need social work, we need home visiting, we need social supports like VIC, supports, financial supports. We need peer recovery coaches, doulas, community health workers, counselors. Really, in order to comprehensively hold, we need the team. Next slide. And that's part of what this clinic, that we all work together, work as a team. We call ourselves the Partnering for the Future Clinic, which already, again, we are not the substance use disorder clinic for pregnant women, because that would be a stigmatizing, kind of off-putting name. But we are partnering with those moms for the future of themselves and their child. This is a clinic located in Ann Arbor at Michigan Medicine in obstetrics, and is deemed to support pregnant patients with opioid use disorder, substance use disorder, chronic pain with long-term opioid use. We offer a safe place so that patients can tell their story and get help. Next slide. This is a team approach from different disciplines named here, and Josh alluded to it a little bit, and we will talk more about that this is a comprehensive approach from various people at the same time. Next slide. This is we offer consultations, co-management referrals, so we can either send the patient can come to us, can be referred from elsewhere. We take over the whole care, or we can co-manage a patient with someone else, with another clinic, and kind of help out, or another clinic just keeps the patient and we just consult. So we have different models how we can help and support the patient and the providers. Next slide. And this is just a depiction as a picture all of what happens in the center is the patient. This is all patient-centered, trauma-informed. And here is addiction medicine, psychiatry, physical therapy for pain management, obstetric care, social work, anesthesia, as Josh was saying, for pain management during labor and postpartum. All of these professions work together. We provide service. We also provide education to the teams and to other providers and the patient. We evaluate our own work. So that's kind of the research piece. We want to know, does it work what we do? And we collaborate with the community, with doulas and other professions. And in that context, we provide lots of counseling where the patient is the driver. The patient can get can get counseling in the office, um, in person, but many patients also feel, actually, I would like to have it from the home virtually, and this is a safe way to engage with therapy. Through a QR code. Next slide. You can see the patient basically signs up through this QR code, and then through the smartphone or a tablet, says, when do I want to work with the clinician, with the counselor, like Chelsea, and then they can do this from the safe environment of their home or from wherever they might be. It could be that home is not safe, then it would be somewhere else that they choose. Finally, last slide, we also offer through the clinic access to a parenting support group that's attachment-based and encourages parent-child bonding and safe parenting strategies postpartum. Okay, next slide, and I'm passing it over to Chelsea, who is our counselor in the clinic and kind of brings this to life as we work together. Thank you.
Great. Thank you, Dr. Music. I am going to try to control the slides. We'll see if it works. Yeah, so as Dr. Music said, I work as a behavioral health consultant in our clinic. I'm trained as a social worker, and I also work as a mental health and substance use therapist. So I kind of bring all of my experience in different settings to this work, and really love working on this comprehensive multidisciplinary team. So we're going to talk a little bit more about what my role looks like with this patient population. Let me see, here we go. So as mentioned before, a big aspect of providing care for birthing people in that we see is addressing social drivers of health. So while prenatal care is vitally important, we know that 80% of health outcomes are driven by non-medical factors. So what happens when patients are not at their appointments obviously has a greater effect than any clinical care that we provide. So examples of social drivers of health would be poverty, would be being underemployed or unemployed, not having a low level of education, maybe not having a high school diploma or a GED, living in an unsafe environment or not having permanent housing at all. A lot of people that we see have very low social support. If they do have support, it's often with other folks in their life, including parents, siblings, who may also be struggling with addiction. And then, we know that the neighborhood, the environment that they live in also affects their feeling of safety, their ability to stay away from substances, as well as systemic factors such as race, sex, and then, of course, their psychological health and the experience of trauma, as Dr. Music shared with us already. So we know that it's very important to try to address these social drivers of health when patients come to us for care, because as seen on this top line here, when a patient presents for care and has unmet social needs, they are not able to access care as consistently, and that leads to poor maternal and neonatal outcomes. But when we assess for unmet needs of um, psychological, physical, and psychosocial, then we can assist and adjust our care plans. We can try to resolve needs and improve access to care and other services, and we know that that produces better outcomes. So, like I said, my role in the team, I am lucky to be able to be there physically in our clinic. The MC3 program generally is an all virtual care program, but with this patient population, it can be helpful to be able to be there to meet them in person, to put a name to a face, and to provide kind of um, a, a warm greeting and just another person to help show them acceptance, and that there's another person that can help provide some resources and support in dealing with some of these needs. So I, along with the rest of the team, screen for things like interpersonal violence, the social drivers of health, and then mental health conditions. And a major role that I play is connecting our patients with referrals to address their needs. So that might be a variety of things, such as for transportation, for if they have food insecurity, linking them to food pantries. If they don't have access to childcare, helping them find childcare assistance programs. And then definitely finding mental health resources to address their needs. So I act typically as um, a more brief intervention therapist with our patients, but definitely try to check in with them frequently to build trust, to reassess their needs, and then provide support in connecting them with the broader health system and coordinating care with all of their providers inside and outside of our clinic, such as outside therapists that they have, maybe a primary care provider that they will return to seeing after pregnancy, um, and any other providers that they might need. And then along with that, we like to find a good, trusting provider for addiction care long term. So if they are on medication for opioid use disorder, I help with assisting them in finding that person so that we can kind of provide that warm handoff to care afterwards. So a big question that a lot of our patients come in with, and a reason that they might delay care, is because of fear of child protective service involvement, which is a very legitimate fear. And we know that a lot of our patients have had bad experiences and more or less have been traumatized by experiences in the past of child protective service involvement, whether their child was removed from their care or whether their rights were terminated or just whether an investigation took place. It can be very, very difficult. And when people are seeking recovery and having a different perspective on parenting and wanting to make different choices, it can be a really scary thing for them going into delivery in the postpartum period. So what's important to know is that unless there's concerns of older children in the home being abused or neglected, we don't have to make reports for substance use in pregnancy. However, after babies are born, we do inform our patients that the baby's meconium, or the first stool after birth, will be collected based on hospital policy. So at Michigan Medicine, there are certain risk factors that indicate whether meconium screen will be sent. And then if that is positive, then that is when a CPS referral is placed. And typically that looks like the Child Protective Services worker coming to visit the parent at the hospital, doing an assessment, and making sure that they are receiving the services that they need and that they have a safe home environment. Typically, people that we see that are in the proper treatment for their opioid or substance use disorder, if they are prescribed medications, they will verify their prescriptions and just ensure that they are, not in a place where they would have their infant be in danger, which majority of our patients are able to take their baby home with them and not have CPS involvement. And I also like to let patients know that CPS can provide resources and can provide opportunities to to obtain things that they do need or supports that they need in place to allow their family to stay intact and or provide for a reunification with children that might have been removed before. So I want to talk a little bit about what a typical patient in our clinic might look like and what we do kind of more explicitly to provide for their needs and to kind of wrap around them and support. So we'll call this patient Carla. She was in her late 30s, white, partnered. This is her first pregnancy. She has a history of substance use and mental health concerns. So was using a variety of substances, namely opioids and cocaine for about the last 10 years of her life, and also had diagnoses of anxiety, depression, and ADHD. Came with little social support and a partner who is also in active addiction. And came into the pregnancy wanting to have a healthy pregnancy and a healthy baby and really wanting to um, stop using, but kind of unsure of how to get there. So um, eventually she was able to transition to a medication for opioid use disorder. And it was it was a difficult transition at first, but she was able to do so with support from our addiction consult team has a nurse that is able to work with patients in that transition and make sure that they are not experiencing withdrawal symptoms, that they're feeling as well as they can be. Um, at that point, a referral is placed for my services. So I was able to initially meet with her virtually and kind of talk through some of these concerns that she had about the pregnancy and really address some of the underlying issues that are we're surrounded by her shame for her choices in life up to this point and really wanting the outcomes for her and her baby to be good, but feeling really worried that she didn't have all the things in place that she needed. So a lot of the things that we were able to do was address her mental health concerns through psychiatry, medication, referring her to a long-term therapist to address her mental health along with her substance use and her trauma that came along with substance use primarily. And then referring her for other support, such as recovery oriented support. So that could look like 12-step groups. There's multiple 12-step groups for a variety of people that want a religious focus or not. There is also just outpatient therapy, again, focused on substance use with mental health. There's trauma-focused therapy that we often refer people to, as Dr. Music educated us on. Many of the patients that we see have extensive histories of trauma that really get in the way of feeling safe enough to seek services initially. So once we've built that trust, we can kind of help them to find providers that are going to care for them the same or similar ways that we would. And then if patients are having a more difficult time entering recovery, we can also help kind of transition them to a residential care during pregnancy or postpartum, where they can, there's actually one facility that they can bring their babies to, and we've had success with patients going there and being able to stay in recovery afterwards. Other services that I was able to refer her to were a home visiting program. There's a statewide program, maternal infant health program, that sends a social worker and a nurse to visit mom and baby and provide resources and kind of screen for health conditions and other things that they need. So someone that's able to be there in the home and provide more tangible needs and just a different support that's able to be kind of side by side with them. And then a lot of what I did in this case was kind of be there for kind of minute by minute or day by day support. So when I was able to, I'm not always able to answer everyone's calls or texts or emails, but for this person, she ran into situations where she just needed some guidance on how to address things such as interpersonal difficulties with family or partner, or how to access different services when there are barriers. And I was able to kind of talk her through those things.
more immediately versus waiting for a once weekly appointment with a therapist or with a different provider. So um, let me see here. So again, collaborative interventions that our whole team kind of utilizes. I do a lot of supportive counseling, talk about coping strategies for dealing with depression, anxiety, also for dealing with urges to use or triggers that might come up related to PTSD, coordinating care with our team and then with other providers, like I said, primary care providers, therapists, other service providers, referrals for long-term care, a lot of psychoeducation about what's normal, what's to be expected in pregnancy and postpartum, mental health wise, labor and delivery. And then the biggest thing for me is unconditional positive regard. So really letting the person know um, that I'm here for them and that they are accepted no matter what choices they make. Because like I said, a lot of the time, and in this case, shame is very much at the forefront of their minds. And I am not someone that needs to add to their feelings of shame. A lot of times, the people in their lives are already showing them that, that they are not necessarily on their team or they're not going to provide support because of the things that they have done in their past or the ways that they've been. So I think I, along with the rest of our team, is able to provide that support and connection when they might not have experienced that before, especially from a medical provider. So, outcomes that we are able to observe. Most of the time, we're able to see a healthy mom and a healthy baby at the end of our work with them. A lot of times they are more connected to recovery support than they were at the beginning of their pregnancy. They may have just started on medication for opioid use or continued on it or started in counseling for the first time to address their trauma or their mental health or their addiction. And then a lot of times, yeah, they're working on kind of long-standing mental health issues that they weren't able to address before because of all the barriers. So we are, I think we're very fortunate to be able to see these kind of really positive outcomes after a lot of hard work is put in to collaborate with them and really show them that they are able to meet the goals that they have for their lives to be healthy and to take their babies home with them um, and to live a different life than they were living before. I think a lot of the times when birthing people come to us with addiction, sometimes pregnancy can really save their lives. So that is something that I think a lot of us feel lucky to witness. And again, the biggest thing is close follow-up and support. So really showing them that we're there for them, that we are consistent, and that we're going to follow through on our word and connect. So I think that we might have shared our contact information before, but if you know anyone who might benefit from our services, whether they have a history of substance use, current substance use, or chronic pain with utilizing opioids for chronic pain management, please direct them to call the OB/GYN department and mention the Partnering for the Future clinic. Usually people get to us if they mention the kind of the right things, but sometimes that can be tricky. And then here's a QR code to our website. If you search Partnering for the Future clinic, we usually pop up. So I think now we will transition to questions and answers. Oh, one more quote. Though no one can go back and make a brand new start, anyone can start from now and make a brand new ending.
Thanks so much, Chelsea, and to all of our presenters this evening. So for the audience, we will be moving on now to your questions. Some of these were submitted already with registration, and if any other questions have come up for you, please go ahead and submit them using the Q&A function at the bottom of your screen. So just to start off with some of the questions that were already submitted, and this was mentioned early on in tonight's presentation, a question about how to talk with pregnant patients about marijuana use, as that is the most common substance use we see. So I'm not sure whether Dr. George or Dr. Music would like to take this one, but it's certainly something hear about a lot, and I'm aware of from friends who've recently gone through pregnancies that there's a lot of chatter on online spaces about utilizing, for example, gummies to manage nausea, etc., and that people just are not aware of the risks that they may be exposing their own bodies to and their babies to with that use.
Josh, do you want to answer, but also get off the slides and maybe
Oh,
we are just kind of bigger things.
there we go. Yeah, I'm happy to start off by addressing that. Um, Thanks, Dr. Quilly, for these questions. The what we know about marijuana, like I mentioned, is limited. And a lot of that has to do with the fact that marijuana is a controlled substance and is not allowed for medical research. So a lot of what we know comes from observing people who have gone through pregnancy and seeing what outcomes come from pregnancy and from their infant and from their child. So we are a little limited from an academic standpoint and a medical standpoint in terms of what we know. What also makes it difficult is that there's a lot of misconception coming from the media and from marijuana companies for exactly the reason that you mentioned. Marijuana is seen as a alternative to medications or a way to help with first trimester nausea and vomiting or hyperemesis. That is, while there may be some symptom relief, we really don't know the impact of that early exposure to marijuana on the developing pregnancy and on childhood outcomes. From the kind of third thing that makes this really difficult is that we often think about medications in terms of dosing and um, how the dose of the medication impacts or the dose of the substance impacts outcomes. And we don't really know if there's a safe or unsafe level of marijuana exposure in pregnancy because what's out there in the market, especially in the state of Michigan, is different from strain to strain or dispensary to dispensary, from gummies to vaping to ingestion. Um, all of it is very different. So it's really hard for us to understand how the dose is impacting the pregnancy. From what we do know, there are some increased risks, like I mentioned, of things like high blood pressure during pregnancy or potentially going into labor early. But the biggest effects that we are starting to understand more of as more time and research passes is the effect on the infant and on the child as they grow up and the impacts on things like neurodevelopmental outcomes. So we really see delays or deficiencies in areas such as like memory, working memory, attention span, and that can manifest differently. But we think about it in terms of things such as like ADHD or difficulty with meeting school milestones. So the counseling that we often provide is that their marijuana while the research and data is limited, what we do know is that it's generally thought to be harmful to pregnancy and to infants after birth. Um, and that there are alternatives, medication safer alternatives that are safe in pregnancy and don't come with those long-term risks for both mom and for baby.
Thanks, Josh. I just want to add, you know, I'm totally kind of this is so familiar because often patients that, when I ask them, um, what is it that you are using marijuana for? Because that's the bottom line. I mean, people don't use anything that they would even think remotely it would be harmful if it wouldn't have some benefit. And so uh, the question is, what is it helping you with? And so they might say, well, it makes me less anxious, or, it's for my moods, or it's the sleep, or nausea. And then we kind of engage in a dialogue. What are the benefits? What are the pros? And what is it that you have heard about? Often people say this is the herbal thing, this is the natural thing, whereas, all these medicines like SSRIs and antidepressants, anxiolytic medicine, sleeping aids, these are like the chemical thing, which in fact, everything is a chemical substance, whether it comes, in the plant. Most medicines are also derived from plants. So first, having the discussion, what is it for? And then kind of maybe to navigate into the discussion, well, is it okay if I tell you a little bit what we know about, all the collective body of knowledge about having this substance be used in pregnancy and exposing your baby. And we have now 20, 30 years of good data collection on what it means to use, for instance, antidepressants and anxiolytics in pregnancy and what is the impact on the developing brain of the baby. And we have actually some longitudinal data on high doses of marijuana exposure on the baby's brain. And if in these three studies, we see what the impacts are. And when you really compare it, the risks and negative outcomes of marijuana on the developing baby's brain of high dose of marijuana. And that's exactly the point that we don't know. Today's marijuana is much more
I was
potent than
just
it was
about to say that.
60
Yeah.
years ago or
Mhm.
50 years ago. We don't know what it is contaminated with. It's laced with different things, but also the potency is high. And we do know that it impacts higher order brain functions like executive function, impulse control, um, aggression centers. So we are setting the baby up with some vulnerability. And parents don't want that for their kiddos. And then we can go back to the discussion and say, so what do we know about medicines that we studied for the last 20 years? What are they doing to the baby's brain? And is there maybe some more safer alternative? Because I get it. They don't want to feel anxious and depressed. Of course not. But do we have safer variants that we can offer? So, and then therapy, of course, is the safest because it has no side effect. It only has benefits if done right.
Great. Really helpful information, I think, for people to be able to share with others. We've had a few questions as well about approaching conversations with individuals who may be exploring the option of addressing their substance use disorder due to pregnancy, and how to reassure them around those fears of um, charges of child protective services. And I know we've touched on it in this presentation, but maybe ways to help alleviate some of those concerns, because it can be a reason why people don't seek care.
Chelsea, do you want to take the lead
Yeah,
on
sure. So I typed an answer to so we inform all of our patients about the limits of HIPAA and confidentiality. So we are not mandated to report substance use in and of itself. So the only reason that we need to break confidentiality, that is to report an individual substance use, is suspected abuse or neglect of a minor, or imminent danger to self or others. So that would be in the case of suicidal risk. But I haven't had it come up where, I guess, or I haven't had it explicitly asked about other criminal conduct or worries. We do have people often that come in with warrants out for their arrest, and I haven't had anyone think that we're going to, call the authorities on them. So we try to work with them to just ensure that they are able to receive care, even while dealing with legal matters. Hope that helps.
Thanks, Chelsea. And it is dependent on each state and state laws as well. So it's if you ever working in another location, it can be helpful to learn that from colleagues. Um, we also had some questions around, what you might see in a newborn after birth. Would there be maybe signs of problems with breathing if there had been exposures to substances, including opioids, and that um, the baby may need more support. So I don't know, Dr. George, if you want to take that one in terms of what can be seen immediately postpartum.
Yeah, sure. I'm happy to. I'm actually gonna put up one of the slides. I know that we went through this one a little quickly, but these cards, and I think somebody had linked it in the chat as one of the resources as well. But these are some of the early warning signs when we think about neonatal opioid withdrawal syndrome. So the withdrawal syndrome is somewhat reflective of what we see when adults go through withdrawal. But since the baby cannot communicate those types of symptoms, we use physical exam and observational signs to kind of get an idea if the baby is at risk for withdrawal. Breathing difficulties is not something that is typically seen, but the most common presentations are irritability, startling and fussing, difficulty with maintaining sleep. The other big things are when we think about a more severe type of syndrome are constant and high-pitched cryings, babies that are like very inconsolable, movements or tone of the baby's extremities that are moving in a jittery or kind of a spastic way. All of these are kind of like more kind of the early symptoms of that opioid withdrawal syndrome. Respiratory difficulty or breathing difficulty immediately at birth isn't typically one of the most common things that we see. And then kind of on the very end or like the most severe end of the syndrome, there is a risk for neonatal seizures. The positive news is that typically we are able to identify things well before they get to that point using this eat, sleep, console methodology. And it really helps for parents to kind of be aware of what to look out for and what symptoms the baby may have, and then different things that parents can do to help soothe and alleviate some of those symptoms with the goal of avoiding a trip to the neonatal ICU. But this program, not just at Michigan, but around the country, has had really great success in earlier identification for parents and then being able to address some of those with very simple and kind of normal parenting interventions. You can probably see a lot of these are things that parents typically do for their babies, like offering pacifiers and consoling and soothing their babies. All these things have been shown to really make an impact on babies' symptoms after birth.
Super, thank you for that. One other question that came through was just around maybe the more subtle warning signs that may be indicators that someone that is in your life may be using or may be struggling with use, and that might help guide ways for you to be supportive of, or helpful to them. So I don't know, Chelsea, if you want to take this one, but maybe some behavioral changes to watch for or signs that you might watch for if you have a concern and are wondering if that's maybe what somebody needs help with addressing.
Just to clarify, I'm sorry, I was trying to answer a question in the chat. You said just things to look for when you suspect that a loved one might be using substances.
Right.
Okay.
Yeah.
Yeah. Yeah, I think that can vary widely based on the substance and also based on the severity of the use. So, there's such a spectrum of recreational use where someone might be quote unquote experimenting all the way to having a significant severe dependence or a use disorder. So I don't know if Dr. Music and Dr. George want to say anything from the medical side of signs to look for physically, but I think behaviorally, when people's behavior drastically changes, when they seem like they're isolating themselves more, they are engaging in more risky behavior. They are doing things, their behavior is outside of the norm for them. I think substances have a variety of impacts on our behavior and our mental health. So um, I think, in pregnancy, we do expect people to have some hormonal changes, of course, that can influence their behavior, but some of those things like changing life circumstances and behavioral patterns, I think, are the biggest thing to look out for. Um, and I think a lot of times, like changing priorities, like not if some of spending time with their kids was a huge value before and now they're not doing that as much, or if they've lost jobs due to not being consistent, things like that. Be happy to hear what you guys have to say as well.
I think you were hitting it right on. You know, being more constricted in your, kind of the way how your priorities, your values were and are, and feeling either more isolative or more erratic in your behavior, maybe more explosive, out of character, and being also defensive. Uh, I think that the most important for it's seek conversation, seek the dialogue, stay on, don't give up, don't, you know, don't let yourself be pushed away. People feel very ashamed where they are, and it's kind of a self-fulfilling spiral downwards because here you feel like individuals know that they're kind of like narrowing in, and it's not, they don't want to use, they don't want to um, behave in this way, but it becomes a self-fulfilling spiral, and then they become defensive or isolate, kind of, talk themselves into minimizing, oh, it's not so bad. And I think just being there and showing your support, being there, having family meetings or staying in touch, not letting them go away or get away, and not getting angry. Sometimes families get angry and then cut off, and I think that's that's in some way also the spirit of our clinic. If somebody doesn't show up, they no show, or they come late, or we just keep at it. We just call them. We just call them again, and we invite them again. There is no closed door. Keep the door open. Keep the dialogue open.
Yeah, that's great advice. I love that.
Josh, what do you think?
No, I think you both hit it right on the head. From the medical perspective, like Chelsea was saying, the presentations can be so variable depending on the substance, but I think overall, a lot of the physical signs that someone may notice are at a later stage of
Mhm.
substance use. The first things that are going to be noticed are those behavioral changes, those mood changes. It's really only when things get to a pretty significant stage of use or severity that you're starting to see signs that may manifest physically. So yeah, 100% agree. It's really about engaging with people, removing the judgment, and just keeping that dialogue open so that this is something that I think we all had to learn. It's really about respecting someone's autonomy and their personhood. And when they're ready to come to have that discussion, that's the right time. So it's about us keeping that open door and yeah, making sure that it's ready when people are ready to have that conversation.
Thank you so much. And I think another pearl maybe for those listening, if you've got someone in your life who's struggled with a substance use disorder and is contemplating a pregnancy or their next pregnancy, and supporting their success can be helping them advocate at their medical visits with their providers to ensure that there's an awareness of those vulnerabilities, and in making decisions about management choices with medications or with procedures and pain management, for example, that everybody's on the same page with reducing risk, can
Yeah,
also be very helpful.
I think that's a really helpful point, and something that sometimes gets lost. OBGYNs, high risk OBs, psychiatrists, our whole team, I think we're very happy to see patients if they're planning pregnancy or before they get pregnant. You don't need to come to us only after that positive pregnancy test. We're really happy to see people and talk about specific issues or advice in what we call like a preconception visit or before pregnancy visit. Those can be really helpful, just setting someone up for success before entering pregnancy.
Well, thank you so much to our audience for listening and to our presenters for their insights. We hope you found this presentation informative. And as we mentioned in the chat, a recording will be shared with you over the next week. That will include links to resources that were mentioned tonight. And thank you so much again for joining us. Take care, everybody.
Thank you for having us. Good
Thank
night,
you.
Thanks,
everyone.
everybody. Take care.
Bye-bye.